I want to thank everybody for coming for Grand Rounds today. We're a very special guest today, Dr. Gavin Britz. He's a native of South Africa, went to the University of Witwatersrand in Johannesburg, and then was interned at Hopkins, and then did his neurosurgery. Actually spent some time at Morley Atkinson in London, but did his training at the University of Washington in Seattle, which is arguably one of the best training programs with Dr. Dick Wynn. He was staff out there. He got a master's of public health there, then went on to get his MBA. He was then at Duke for a while, and then he took some assignment as chairman of Methodist. He's also a professor at Cornell. He's published extensively, over 100 publications, a lot of book chapters, and then NIH funded a lot of basic research, and now has a wonderful training program there. So we're very fortunate to have time out of his busy schedule to be with us, and we have a very interesting talk about innovation. So without much further ado, Dr. Gavin Britz.
So thanks, Anil. Thanks for giving me that nice invite. It's a pleasure to be here. I actually only left the OR last night at 10 o'clock, and I speak fast as it is, and when I get tired, I speak faster, so try and slow me down. So I said to Anil, this is not going to be any high-powered lecture, but I'm going to give you a lecture on how my career has changed. This lecture is basically geared towards the residents in neurosurgery and neurology. So what I'm talking about today is the continued need for innovation and change in neurosurgery, not the innovation itself, but how we as human beings need to embrace it. And I know Neil's going to like this slide because he's a philosophy major. And as you can see, this is one of my favorite guys. And the reason being, he's a Greek philosopher, but he's well known for two things. He's well known for one thing, which is more important, but I think the other thing is more important. And he's the guy that said everything changes. You never put your foot into the same piece of water at the same time. But also, he regarded himself as a pioneer of the term wisdom. And I think wisdom, when you look what wisdom is, what is wisdom? I think people look at wisdom as an IQ, etc. But I don't think wisdom is an IQ. Wisdom is more to do with what you value, more of EQ. And so when I look at that philosopher, I think the two things I take home is that everything changes. Look at us to the left. We are born. Let me see where this is. We live, we grow, we reproduce, we regress. I'm in that phase now because my kids are married. And then we die. So, we are constantly changing. But I think the biggest thing I've taken from this guy is the term wisdom. And I think, as Neil knows, I'm a pretty religious guy, multiple religions. But as Proverbs says, the man that knows right from wrong and has good judgment and wisdom is the wealthiest guy in the world. And this wisdom isn't IQ. It's to do with how you value life, how you look at people, how you treat people. And that's something you cannot buy. So that's what we're going to really talk about today in my talk. And I think when you look at neurosurgery, it's no different. You have to look at evolution. It's changing all the time. When I look at the procedures I'm doing now, and I'll show you in my short career, it's completely different to what I did when I trained in neurosurgery. We never had coiling when I trained. We never had minimally invasive spine surgery when I trained. And that's something we're doing and embracing all the time. So we have got to continue to adapt. And the second part is the wisdom. And I think Anil knows, you find some neurosurgeons or even neurologists that are out there practicing stuff that is outdated, that's 30, 40 years old. And you have to have the wisdom as a neurosurgeon to embrace the changes and do what's best for patients. So I'd say, always think of these two things as you practice neurosurgery long term. I'm going to base my talk, I think as you guys know, I'm a vascular and skull-based neurosurgeon. And I was trained with Dick Wynn, and I think people that know Dick Wynn, little crazy guy. We clipped 6 basilisks some days, and I was really keen on vascular neurosurgery. I was a Ferrari guy, car guy, and I said, I'm going to be open vascular neurosurgeon. Why? It was, adrenaline, particularly demanding. It was the Schumacher of neurosurgery, so that's what I thought I'd do. And you must understand, I only finished my fellowship in 2003, which is only 13 years ago, and I'll show you how my career has changed over this time period. So I prepared myself well. From 1993 as a resident, and I did a couple of fellowships. I trained in a strong program. We did 300 aneurysms a year. I did every open vascular case I could. I stole every aneurysm from the other residents. I learned all the skull-based approaches. And I even went to the Walter Reed to do the Bolt bypass course. I also watched Shaker. We overlapped with Seattle. And I thought at that time I was a superb open vascular surgeon. I thought this is my career. And I learned endovascular. I did a 2-year fellowship, but it wasn't my true love. Okay? And this is what I was hoping to do, So this is what I'm going to do my whole life. Look at the Spencer's articles, all these guys, the cardiac standstills, flipping the giant basilisks, the vein and radial artery bypasses, doing the 20-hour AVMs. This is what I trained to do. I spent the whole 11, 12 years in Seattle learning how to be an open vascular surgeon. That was going to be me, the Formula One racing car driver, okay? This is what I did, and I really perfected it pretty well. You know, we did the giant basilar clippings, we did the vein bypasses, enterocirculation, postcirculation, but I also improved my endovascular skills, but that's what I did. I focused on that, okay? From then until now, unfortunately, it's changed. And I'll show you my practice time. This is what it looked like. I trained and spent all my 11 years writing every paper I could, doing every open vascular case I could. And now the field was changing. So often, and still today, I'm sure Mike Norton feels the same way, but that's how I feel sometimes, okay? I looked at coiling versus clipping, and that was me, the real man, you know, Dick Wern, Spencer, big guys, and these were the nerds. And that was the field I was competing against. Even though I did both, I didn't want to accept it, okay? And as we all know, now as I practice neurosurgery, I'm no longer the Formula One racing car driver. I drive go-karts because that's what endovascular is about, okay? And the reason why, people say, you know, why did it change? And I think we have to understand, you know, what drove the change. And this is the reason. Catheters were developed that we can migrate in the vascular system, go to any part of the vascular tree, and that totally changed the endovascular arena and changed vascular surgery for me. This was changed further in 1991 when the detachable coil was developed. I think we went inside before, the first coils you couldn't detach, there were a lot of complications. But in 1991, that's when things really changed. That was 10 years before I finished my residency, or 12 years. But that single coil changed my career path, and I never saw it coming. I mean, we all said, Dick Wynn said, you know, coils, a miracle glow, aneurysms will grow, but that changed it. That was the first time you can go inside, coil the aneurysm, wasn't superb, pull the coil out and replace it. That changed the career. Endovascular, in comparison to open surgical, we did this great skull-based approaches. It got better. We did brain oxidation techniques with neuroanesthesia, lumbar drain, but still it required the brain to be open. So when I look back now, and I see myself after that, seeing the endovascular field growing and, you know, my open vascular getting less, and I look back at it's come a long way. Look at the early surgical. John Hunter, if I was born in 784, I'd be treating the aneurysms, clipping a carotid. Victor Horsley first exposed the aneurysm. Cushing clipped the first one in 1911. Norman Dot put muscle, and Walter Dandy did the real first clip occlusion in 1937. So as you can see now, that's what we do in neurosurgery. We are continually evolving field. But look at how the evolution occurred over 100 years, just to go from ligation to that. And look where we've gone over the last 12 years. Endovascular, I think the first big 1900s, direct punch of aneurysm, folded up. Moniz really changed cerebrovascular when he developed the angiography. Lussenpop did the first intravascular approach to lesions, and then Rothberg and Sabenko did the first balloons. But up to 74, until 1991, endovascular was a second-rate treatment because you couldn't successfully call the aneurysm without having major complications. But that just gives you an idea. I think for myself, and we all do this with new technology, acceptance of the endovascular wasn't easy for me. And we all go through the first of these phases in any technology, the awareness, interest, evaluation, trial, and then we adopt it. And this is what changed the program. I was so against it that I wrote the editorial in the Lancet saying, it's not here to stay. So even myself, even though I preach wisdom in other parts of my life, this is the one part I didn't want to accept. But this completely changed the practice, okay? So when I look at this, I treated these cases in less than 5 years from, so we obviously at that stage, my endovascular practice was growing, my open vascular practice was getting less. But these are the cases I really enjoyed. I said, well, I'm still going to do the endovascular bypass. We cannot call these aneurysms. This is a broad-based aneurysm. I think with the endovascular eyes and Neil, this is a big paraclinoid clot inside there. This is a stent coil, cannot stent coil. This is a bypass. So I will still have a role. And this is what I did. This is what I did at Duke. Every 3 weeks, a high-flow bypass. Veins, radial arteries, whatever it needed. And I did a pretty good job. 85% success rate, but some complications. I remember this case very clearly. This is how things change for you. This is a 76-year-old lady was visiting from Australia and had this aneurysm, and she had to go back. And I said to her, she was a Duke case. This changed my career completely. This lady, she had double vision, that is acute double vision as well, and she was going to be in America for about 6 weeks. And I did the angiogram, and I'd just done the flow diversion course, the training in Buffalo, and I came back and said, ma'am, you've got an isolated circulation, there's no ACOM. What I can do for you is I can do the bypass. I said, but it's going to require, you know, open your head, take in the radial artery, and even in an experienced person's hands, at that time I was, complication rates at least 15%. I said, I've just trained, I've never done one by myself, but I can put this new stent called a flow divert inside. Doesn't require your head open. You'd be my first case. And she's 76. You know what? I want to be your first case. And that's the result. And that case, I always remember it. That was probably the biggest heartache for me, is when I saw that post-op angio. That's before she flew back to Australia. The aneurysm gone. And that's the advent of a new technology called flow diversion. So we take a step back. We were clipping aneurysms. We did carotid sacrifice. Then the endovascular arena came out. We were coiling the aneurysm, took away the clipping. And I said, finally, we'll have one thing they cannot take away. And then flow diversion came around and took it away. So we as neurosurgeons understand this is a continually evolving field, and you need to embrace that changes, unlike me. And this is our field, coming from South Africa as a microvascular surgeon. Even though I do endovascular, there's always a new technology around that's coming back. We're busy writing a paper now on our flow diversion cases. And 5 years ago, our complications for flow diversion was 18 to 20%. We've got them down to now, between Orlando, Richard, Jonathan Zhang, and myself, to about 3%. So there's no ways, I don't care how good a surgeon you are, you cannot compete with 3% complication rate for the giant paraclinar aneurysms anymore. So it's getting better all the time, okay? But again, you know, you must also have wisdom. I think endovascular is good, but our big thing, to all the residents, first do no harm. And the treatment must be never worse the disease, and aneurysm is no different. So therefore, just for you guys, for the academics, such as Anil, where it came from, Worthington, no one understands where it's come from, but that's an important phrase we as neurosurgeons, particularly residents and physicians, have to live by. And you often, you know, I see it, even with my own faculty, some decisions are not the best. You know, is it the best for the patient? But really, this is something you've really got to live by. And if you live by that, you'll have a low lawsuit rate, and you'll be a better doctor. I always tell my residents, be a doctor first and a surgeon second. And I think the endovascular, even look at this, in regard to the stroke. I think the guys who's a stroke neurologist inside here, I was with Duke with Larry Goldstein. I think you guys know him, a real famous neurologist. But whenever a stroke patient came inside, we wanted to do the embolectomy. They said, Gavin, that's immoral, that's just purely for money, etc., etc. Until February 2015, that was just over a year and a half ago, where we did almost no thrombectomies, and those 4 trials came inside, and suddenly a breakthrough in regard to endovascular. So even in stroke therapy, we now set the stage for thrombectomies as a standard of care for stroke. So again, a clear example, as the field is changing rapidly, we must adapt to that field. So now we look at it as a vascular surgeon. What are the options? You've really got to look at all the options. Simple coiling, stent-assisted coiling, which is getting less, balloon-assisted coiling, which is getting less, flow diversion, which is getting more, vessel sacrifice, which is almost unheard of these days, and the surgical is clipping, clip reconstruction, trapping, and trapping bypass. And I think a good endovascular surgeon today, a good vascular surgeon in modern day, I know Neil's very good, has to look at all these different options. If you cannot do it all, at least offer it to your partner to look at all these cases. Okay? So important, I think, as a good surgeon, look at all these tools available. There's examples for the residents and neurologists. You know, have your hammer, that's your clip, that's your coil, stent coiling, that's your bypasses, that's your reconstructions, and that's your flow diversion. You have to offer every patient you see one of these options. So we were talking earlier to Anil about a patient for a basilar. I know for a fact when I train this basilar, straight up, this will get clipped. Patient would come inside, subtemporal approach by Dr. Wynn. If I did it by myself, I do a transsylvian, anterofascial transsylvian approach to clip it. These days, patient comes inside, gets called, goes home the next day. Again, we've adapted to the times, and that's what the patient needs for now. People say clipping should never be done these days, and I'll show you my data later, but I still think that clipping has a role. This is a periclosal aneurysm. It's broad-based. It's involving different branches. I know you can get a coil inside there, and you can put an Elvis Jr. stent inside there, but I guarantee you now your risk is going to be far higher for an Elvis Jr. stent and coiling than going to do a simple clip. So again, do what's best for the patient. Look at every patient, look at aneurysm factors and patient factors when you make a decision how to treat these aneurysms. So I look at my data now in 2016 of ruptured aneurysms. Half of them I treat endovascular, but the biggest, and particularly at Methodist, which is a largely unruptured practice, 90% of my cases I treat unruptured. Anil, what do you guys do here? How much unruptured? 50-50. So, I mean, this is the thing, you know, with having 4 aggressive endovascular guys as well, my rate of unruptured aneurysms is 90%. You take me back 7 years, it's about 30% endovascular and 70% open, and that's how it's changed in the last 5 to 7 years. So you guys who are a lot younger than me will see technology change, and it's changing rapidly by the day, and you have to embrace it. But obviously, I always say to people is that, you know, very few of us are going to make major discoveries in medicine. Let's be honest. You know, we're not all Cushings, we're not all geniuses, but I think all of us have to try to make some difference. So, when I looked at it when I was an open guy, the cardiac stand stop is tempered clipping. I think Cornel's a lot of aneurysms. Some aneurysms are large, and if you want to get a good result with the clipping, you've got to see around the aneurysm. I always say circumferential visualization of the aneurysm, the branch, and the perforates will give you results. And obviously, we went through the phases of traditional cardiac still, stop the heart, fem, bypass, cool the patients. I did very few as an attending. I probably did 2, but I did a lot as a resident, okay? And our complication rates, I don't care whose hands, is 50%. Hematomas, blood clots in the head, etc. So that really has been phased out. Tempered clipping, I like tempered clipping, but again, it induces spasm. People with atherosclerosis, I think the stroke rate's high. And also in very narrow spaces and narrow surgical corridors, it takes away the space you have. So I thought about it, and we started doing it in Seattle. Unfortunately, the guys published it ahead of us a couple of weeks before from the Dallas group. Now, we hadn't Page from Chicago at that time, but we were the first guys to do this. And what we started to do is adenosine and adenosine arrest. So what adenosine does, it stops the heart. People did that for for atrial flutter and the cardiologists, and it stops the heart. And I'll show you some cases. It allows you to stop the heart, collapse the aneurysm around, and you get the same result as a traditional circle arrest without having the problems of having all the hypertension, all the blood clotting problems, and also not having tempered clips in your way. And I'll show you an example. And we got that published in Neurosurgery. So again, I didn't cure cancer, but even this small little role, I think I played a role in outcomes in patients. This is a schematic before I show you a real case. That's a complex ACOM. And I know you get a big ACOM like this, the biggest risk you have is taking the A2s on the other side. And if you don't see the humerus, don't see the perforates, you're going to have a humerus stroke at least. And with the adenosine cardiac arrest, you can stop it, and that's the visualization, and you can clip the aneurysm. Just give you a show. This is a PCOM I did. That's the ICA. That's the skull base. A1, M1. That's the number 4 pen field. Push as hard as I can get, okay, and I cannot push it. So I cannot see the PCOM well. Stop the heart, collapses down, because that's the brainstem. So when you collapse this large aneurysm with adenosine, you can see around it and see better, and that's the clip application. I've used that technique to now clip, very complicated ACOM aneurysms, very complicated IC aneurysms. This is a lady I actually prepped for a bypass. This was done in Seattle, but with adenosine, could collapse it down and do clip reconstruction. That's a giant PCOM, and most people look at the aneurysm and say, this has got thrombosis. You're going to have to open it up and do a bypass. I prepped for bypass, but with a smallish neck, put a clip on it and cleared it out. So for me, in my own little way, and same with the BASDA. This is a big BASDA, brainstem compression, adenosine cardiac arrest, got a good result and sheeted well, and I clipped a PCOM on the MCA a couple of weeks later. So for me, the technology is good, but I do think we have a responsibility to help change the field as well. And I've used that extensively now in almost all my clippings, except MCAs. I still use adenosine even at Methodist now. Some cases, again, despite the endovascular being around, this one I just didn't, last year, big giant MCA, you're still going to need to clip those aneurysms. So overall, for the residents, you've got to see how I have changed my practice, and I'll give you my actual data a little later. It's completely changed. I was a completely open vascular neurosurgeon, doing mainly vascular and doing all the complicated open cases. But now, with all the new technology, it's completely shifted towards the endovascular arena. Is endovascular dysphagia? And I think we've always got to be honest with ourselves. I think if you're not honest, I always say there's no greater fool than the man that fools himself. And I think take a step back and think what I'm saying. We fool ourselves. We spoke about it in the office a few seconds ago, and it's true. I think you have to be honest with yourself and be honest with others if you're going to be a good surgeon. So is endovascular dysphagia that people say it is at the moment? I think it is, but not completely. I'll give you a case to show you why. This little kid, 10-year-old, with a Perry-Romberg disease. I think some of the neurologists will know what it is. And he had some decreased vision in the left eye. We've got an MRA and a CTA. As you can see, this large fusiform aneurysm. So we've got the angiogram, and clearly this fusiform aneurysm. So this is a kid that needed one of two options, either a bypass or a flow diversion. And I showed you early data. Flow diversion is the way to go. And I thought so as well. However, I did tell the family that, this is a little bit more distal and I like it, and more proximal. We may need to place a few stents. Family said they went all over the country, said, we'll come with you, get it done. Went inside, put this pipeline, got a really good result, and that's immediate post-op angio, and it's already stasis. So I said to myself, well, again, Gavin, you were wrong. You wanted to do the bypass, but you ended up doing the flow diversion. This is a great result. 1 month follow-up angiogram. Sorry. That's the result. I mean, that's phenomenal. No bypass, no skin incision, etc., etc. Patient then comes back about 6 weeks later and says, you know what, my kid's going blind. And this mother was, Neil will know what I'm trying to say, she's a Jewish lady, very intense, said, my kid's going blind. I said to her, we just did the angio a week ago. I said, well, I was thinking to myself, well, we must have knocked off the ophthalmic artery that's spiny thrombosed. So I said, well, go to ophthalmology first and bitemporal hemanopia. So I said, this doesn't make sense. We get an MRI scan quickly, and despite having the angiogram showing a great result, this aneurysm's got bigger. So exactly, and we actually looked at that, and that kid actually ended up having a bypass. But just to show you examples, so even though you think you get a good result, the technology is still there to be tampered with and played with and understood. But use that technology, but also be smart about it. Talking about flow diverters, I said to you before, and Adnan Sadiq and myself, we combined our series with the 7 patients with posterior circulation flow diverters. And I know they still continue to do that. And look at our results. Of the 7 patients, 4 patients died. Okay. 3 patients had MRI scores of 5, severe disability. These were all, except for one was a ruptured patient. These were all unruptured patients. Okay, and I always show this slide, and I showed her, Neil, you guys know this guy's from Buffalo. I said, those results almost like Dr. Kevorkian, 57 clean kill and 100% complication rate. So when I look at those cases now, flow diversion for those giant aneurysms in the bad circulation should be avoided. Unfortunately, people are still doing it, and even that group I'm talking about now. So again, even though flow diversion, stent coiling is the way of the future, understand that it's not completely the answer. And this is one of your residents going to do a fellowship. This is a case I just did recently. Simple coiling, there's the ACOM aneurysm. I said, this will take me 20 minutes. Take the microcatheter inside, they do my first run, branch gone. I said, wow, this is crazy. Then I said, okay, I'll quickly call the aneurysm and open it up. But even a simple case in endovascular can have complications. So no procedure, no technology is completely risk-free, and you must understand that as well when you make a decision. Obviously, this sounds a little depressing, particularly for me, doing all the open stuff. I think vascular is still exciting, and in some cases, we don't have a solution. I think what O'Neill says. This is a guy, 42-year-old guy, 2 history of progressive bulbar palsy, left side hemiparesis, and that's what the MRI scan shows. Clear dissecting aneurysm. He's got a few strokes in his brainstem already, so I knew before the angio, this is a dissecting aneurysm in the basilar. We get the angiogram. Look at that. We do an Alcock test, no PCOMs, and this is clearly a dissecting aneurysm of the basilar. What do you do? So I actually watched him for a couple of months, and he got worse and worse and worse. So I said to myself, well, what do? We can go and we can't put a flow diverter. I've seen the results. I can't, take that one vertebral artery. You'll stroke out because you've got no PCOMs. So I said, well, what if we do is if we reverse the flow. If it's a dissecting aneurysm, the flow should be prograde. So if I do a bypass and get flow to go retrograde, that should cure the dissection. And that's what I did. I did a radial artery graft, PCA bypass, occluded the vert endovascular. Patient did no better and finally died about 2 years later. So some of these cases, I don't think we have answers. People are putting flow diverters in them. People are putting trappings. But in my hands, I have no answer. Neil, what do you think of these cases? What do you do? Bad outcome. And I think that we need to. So for the young vascular guys, that's a case we haven't found a solution. You can do the most complicated cases, they still die. Okay, so that's the exciting part. And I think we also, as neurosurgeons, we've got to push the frontiers. And this is another area that we need to address. These are case series I wrote with people presented with posterior circulation strokes. Look at the angio. You've got the ICAs, both verts are gone. And on this angio, you can see the pre-op. There's just trickle filling of the PCOM. So I did 3 of these cases, and every time they sit up, they pass out from VBI. And those are the cases I took down, and did a bypass. Again, radial artery to PCA and filled it up, and that made a complete difference. And we just published our series. Complication rates are high. Of these 3 cases I did for those situations, the complication rate was 1 out of 3. But again, in 2 out of 3 patients, I made their lives better. I think that's what neurosurgeons. We cannot cure everybody. But at least we should try and make this better. So, as I said to you guys, again, this is a talk about how things change. And I'll show you a case now of cavernous malformations. When I trained in neurosurgery, even at Duke, a deep-seated cavernous malformation used to be a big craniotomy, a big corticectomy, go inside, take these lesions out. This is a guy who came, 20-year-old, presented with acute onset of complete left-sided weakness, hemiparesis, 6 months, seen one neurologist, followed up over time. And that's his MRI scan. So before new technology was around, we'd look at the scan and say, well, there's many approaches. We can go transventricular, we can go, post through the pulvinar thalamus. But these are difficult cases, and I can do this now, or through the lateral insula, which is the easiest way to go. But I guarantee now, with new to old technology, the chance of having a major complication is high. So what we do now, and I do this all my subcortical cases, we get DTIs, and what it showed is that the motor cortex, going to go back, was unlike, obviously we know the motor cortex stands, goes anterior and slips around the brainstem, and his motor cortex, or the DTIs, was wrapping around it. So if I came lateral, we would have been straight through motor cortex. So instead, I took brain path with a synaptive robot, took this tube, went extremely medial and very far forward, so slipped into the motor fibers and then sneaked in between the motor fibers, you can see there, into the cavernous malformation and went all the way into the brainstem and took it out. And we did this awake, and that's the post-op result. We've got that published as well. So again, things are changing so rapidly in vascular that you've got to keep up to date with it, and you've got to be doing the latest cases available if you want to be top of the field. I talked earlier, ICHs. I think, we know the STITS trial was done by a South African guy, Dave Mendlow, in London, which showed hematomas, leave them alone. But I think now with the MISTY trial coming out and the stuff for brain path, we're going to really change the way we treat these conditions. This is a guy who came in the other day, big hemorrhagic stroke. I used the synaptive robot, put a little brain path. We get DTIs in all these cases, go below the supralongitudinal fasciculus, and which is basically just above the eyebrow, and put this brain path and get the hematoma. So again, we're not taking a great condition, we're taking a bad condition, a bad patient, but we're optimizing his recovery. So whenever I do these cases, this patient will get a CTA, make sure there's a vascular lesion, get an MRI with DTIs, and I'll even preserve the oculofasciculus. I'll try and preserve the supralongitudinal fasciculus, and I'll use everything in my power to make sure the patient has a good result. And I think the synaptive robot we talked about earlier is going to be changing the way we treat the ICH hematomas. So my practice, this is what the talk's about. 2003, 2007, this is my Seattle time. 60% of my practice was open vascular, 20% endovascular, because I was mainly a heavy open vascular guy, and about 20% general neurosurgery included spine, okay? Then I went off to Duke. I dropped down to 40% open vascular, because we still did all the hypo bypasses, 40% endovascular, and 20% skull base. And now at Methodist, 15% open vascular, 25% endovascular, 10% intrauterine tumors, and the vast majority of my practice now is complicated skull base. So you can see, and I only finished 13 years ago. In 13 years ago, I've evolved from essentially an open vascular neurosurgeon to now a skull-based surgeon. So I'm completely different, okay? And I think it's my responsibility, as the Greek philosopher said, to embrace, promote the changes in these fields. So now I'm not only doing vascular, so this is another thing we try to do. So this is, as we know, third ventricle. I saw in a case you guys did the other day. Third ventricle, there's many different ways to get there, particularly the anterior third ventricle. I think most of us used to do the transcallosal or the subfrontal approach. And I think, as the era of understanding white matter tracts is around, you've really got to preserve white matter tracts. And if I have a colloid cyst or a third ventricular tumor, I like my fornices, I like my white matter tracts. I don't care whose hands, when you manipulate these structures, be it transforaminal, interforniceal, or transchoroidal, you're going to damage the fornices. In my experience, those guys are never the same again. Even if it's mild memory loss, they are never the same again. One approach that hadn't been ascribed was a subcallosal. And that is an approach, and I talked to the residents earlier, is where you combine an intrahemispheric approach with a subfrontal approach. The downfalls of a subfrontal approach, the classic one, which you take both frontal lobes, you retract them, they're both bruised post-op, you cut the sinus, you go down there, and you get a great exposure, and you also approach that area through the subchiasmatic window, which is a real small window, which I'll show you. The nice thing about a transcallosal is it's intrahemispheric. You don't damage fiber tracts until you get the corpus callosum, and then you take the corpus callosum. And as a religious guy, God gave me the corpus callosum for a reason. I mean, that connects the brain. It's a thick white matter tract. So that's the disadvantage, but the advantage is the intrahemispheric approach. So when you combine with neuronavigation now and a subcallosal, you can do a small craniotomy, just do an intrahemispheric approach, and come underneath the genie of the corpus callosum without even touching it, and I'll show you the window you get. And the biggest people said to me, Gavin, you do this approach, you're going to have a much longer reach. So we did an anatomical study with a couple of cadavers, and that's the only difference. So subcallosal is minimally longer, but now you've approached that doesn't damage white matter fibers and gives you a really great corridor, and I'll show you the corridor now. So your traditional approach, that's the approach we have now, above the communicators. You're going to come beneath the genu, follow this A2s, there's your corpus callosum, and that's your working window. And you can see a vast corridor. If you go the subfrontal approach, you're going to have that's your window you're going to get. So I think this is combining the benefits of the interhemispheric transcallosal with the subfrontal approach, and you get a much better view. And these are some cases I've done. This is a 44-year-old female, sudden headache, memory loss, cystic area, ideal case. Look at this case on the coronal, on the sagittal. Navigation gets me right down there, and people say, well, it's high up. But if you rotate the head, if you extend the head, you can change that angle, so you can be looking up this way. The frontal sinus were pretty small. I don't care. I'll take them anyway. You can get inside there through a small craniotomy without damaging any of the structures. Another case, craniopharyngioma, which is very similar to the one I showed you earlier. You guys showed me earlier. Same approach. Here's post-op scans, and this is the post-op scans of the other lady. And more importantly, the frontal lobes look great. There's no damage, and we just got that published as well. So I think I don't want to waste too much of your time, but it got to as you can see in my practice, it's completely changed. In 13 years, I've gone from an open vascular neurosurgeon to a complete skull-based surgeon, doing all types of tumors, still doing open vascular and still doing endovascular, but embracing the changes. Let's talk about research as well. Okay, so obviously I have some labs as well, and I look at my lab research as changing as well. I started this as say, I think Anil will remember, post-subarachnoid, you can be the best surgeon, the best endovascular guy. You have a bad subarachnoid, you're never the same again. And no one really understands why, okay? And I think we still don't. But I said to myself, one of the first things were, what about the microcirculation? I had the luxury of having Dick Wynn's microcirculation lab available. When he looked at adenosine, I said, let's see what subarachnoid hemorrhage does to the microcirculation. And that's what we focused on initially, and now we're focusing on that, and I'll show you why, okay? So the hypothesis is that, why are these people never the same again? Some people have major strokes, some people have contusions, but many of the brains are pretty good, okay? So my hypothesis was, all those years ago, and was supported by the American Heart mainly, is that the subarachnoid hemorrhage alters the arteriolar function, both the penetrating appeal, and then results in abnormal activity, abnormal CBF regulation, and obviously abnormal vascular communication, which leads to strokes. And that's what my hypothesis was. You're going to have small vessel strokes, and worsening of the effects of the large vessel spasm and significant morbidity. So, and just for the residents, not going to go into detail, but as you understand, this neurovascular unit is very important. People are debating if it is really the neurovascular unit at the moment, but you need this unit to perform well to make sure the patients are getting enough blood supply. If this is affected in any way, we're going to get the small vessel strokes. And what was it based on the data? So I started this before, but I did look at Gerard's study, which showed that people had deficits on CT with absence of vasospasm on angiography. Gavin later, after this research was done already, also showed we had hyperresponsive peel arteries post-stroke, and also the intraoperative evidence. But the biggest study that confirmed what I was looking at was this paper by Rubinstein in stroke, which showed perforated strokes in subarachnoid patients that were not in a major vascular distribution, which supports the hypothesis that microcirculation may play a major role. So that gave me impetus and gave us funding. So the first question was, is there normal peel arterial activity following subarachnoid hemorrhage? Not to bore you details, cranial window, stimulated with SSAPs, and we recorded how these peel vessels would respond to stimulation, because what you expect, stimulate the femoral nerve, the peel vessel would dilate. And we measured them pre and post, and what you can see here is these peel arteries are completely abnormal, even to normal stimulation, but then even add in some agents, which I'm going to go into details for a basic science lecture, but clearly this showed that the peel circulations were abnormal. We then said, the peel's abnormal. What is the penetrate? These are the arteries that go from the surface of the brain into the brain. How abnormal are they? And we did the microvascular pipette, same thing, caliber, stimulate, subarachnoid versus not subarachnoid controls. And this is what we published as well, clearly completely abnormal. So we were onto something there now and showed that the microcirculation was completely affected, and then went into the whole ramifications of what the mechanism was, and we clearly showed with many mediators of vascular cupping, this is completely abnormal, depressed, and lasted so for 2 to 3 days, okay? And obviously people don't know about this, but look at the microcirculation. That's the basilar artery, normal, 48 hours, and subarachnoid, internal corrugation, clearly vasospasm. But more important, even the arterioles and the temporal lobe had evidence of corrugation. So clearly, we had physiological evidence of abnormal microcirculation, but also anatomical evidence that the microcirculation wasn't working. And what does this mean? Just basically, it may mean that people are not the same again because you have poor circulation, poor CBF, poor regulation of CBF, resulting in small vessel strokes that we can't really see on MRI scan sometimes. And I'm not going to details, but as we know, the hippocampus is the core area of the limbic function, controls who you are. And again, talked about earlier, we're not going to cure science, most of us. But going back to the history, there's a very, very smart guy called Weill that even in 1978 showed that the hippocampus is the one area of the brain that has very, very sparse vascularization. So we know if you have a major trauma, hippocampus dies. Okay, people say it's purely from trauma, but it's not. It's also from a vascular. So the same thing can be translated into the subarachnoid hemorrhage patients. These people can have a hemorrhage, the microcirculation system isn't working, and you're going to clearly find that. So at that time, we had the microcirculation, peel penetrating, and the anatomical evidence of the vessels are abnormal, and then we looked at the hippocampus as well, which clearly shows it's abnormal. So our hypothesis from the lab is that the microcirculation plays a major, major role in regard to how people do badly post-subarachnoid. And then we obviously started with this, with in vivo hippocampal preparation, not into details for the basic science, but it clearly showed the stimulation, that's what normal looks like, and that's inside the stimulation area. But if you look at that, we just published that as well in neuroscience. When you look at a response to normal versus subarachnoid, so you got a cell, that's the oxygen tension in the hippocampus, you stimulate it, it needs more oxygen, it goes up. Look at the subarachnoid rats, is that the baseline oxygen is high, which is like superoxide, and instead of going up for demand, it goes down. So clearly we've shown that the vessels, even indirectly in the hippocampus, are completely abnormal in regard to subarachnoid hemorrhage. So, we've done that in vivo now as well, we're going on to that. So just in summary for the lab stuff is that I've changed it. We've clearly shown it's work, but again, I still haven't understood what's the mechanism. We can say they don't work as well, but not. Then we're going to go into the CSF. Another area of my interest now is looking at why these vessels are going into spasm and why they're not normal. And, And we're looking at now the CSF flow. And I think people, have you heard of the G lymphatic pathways, Neil? So G lymphatics I think is a really important part of the brain. I think a lady called Liedergaard described it first in regard to sleep. And what the G lymphatic pathways is your lymphatics of the brain. And so, and what we're looking at now in regard to the brain, we just got this published in JCBF, which is in press now, is that the G lymphatics takes away the waste of the brain. And so the hypothesis now from the lab is if your subarachnoid hemorrhage is inside there, it blocks the G lymphatic pathways, you cannot get the solutes out that aren't supposed to be there. That'll result in microcirculation arrest. They're not working well, and that'll result in this decreased function. But I think that's for the residents who don't know about this pathway. This is extremely pathway. And for book club or journal club, I'd look at the G lymphatic pathway, and when our publication comes out, we'll send it to you guys as well. But as you can see, that's where we're going now, and that's what my lab's doing now, and it's pretty cool work. That's the PhD, just adding the stuff here. But that's within a nutshell. But as you can see yourself, not only clinically, but in research, you're continually evolving and trying to understand and answer important questions. And I think that, for me, as an academic neurosurgeon, makes my career so much more exciting. Thanks very much. I'll look at the details, but. It's a lot of talking.
I think very rich Manger. I think some of our residents will be doing high-risk cardiothoracic surgery. I think you're right. I mean, things are very changed. I mean, I tell the residents, I didn't know how to put a pedicle screw in when I trained.
Yeah.
And you need to learn. So I think the important thing, the message for the residents, I'd like to resonate with that, is that it makes a big difference. The field keeps changing. It's like Heraclitus. No river is the same when you.
That's true, and it's so true, yeah. And if you don't adapt and you don't embrace it, you're going to fall behind and you're going to hurt patients. I think that technologies, I could look at spine. When we trained in Neil, there was no minimally invasive spine. Now these guys do. One of my partners, Alex West, does these, lateral T-lifts. Like a little tube like this, puts it right through the retrocranial space into the body. I mean, it's crazy. So if you don't adapt and do those new technologies, you're going to fall behind and you're going to hurt your patients. There's no doubt about it.
Any questions? Extend to a question, Dr. Quaker.
It was a great talk. I mean, I agree with what you said, especially doing the vascularization, which sometimes is the hardest part. Like,
I just think,
whether to do one or the other.
And I remember I was at Hopkins there with Cameron, and I remember when they did the laparoscopic choles, I was doing general surgery there, and the complication rate was crazy high. And Cameron was saying, this is terrible, this is immoral, this is the companies driving it. And Cameron was, I mean, I respect him immensely. He was there at 4:30 in the morning and left at 11 o'clock. But I look back and I agreed with him. But now, retrospectively, it was just the technology needed to improve. So photo version, I'll be honest with you, I mean, in front of audience, I was against photo version. I loved those bypasses. And when the complication rates were 18%, I could justify still saying, you know what, sometimes I should do a bypass. Now at 3%, I can't. So I think, the technology, you've got to embrace technology, but be honest with yourself, be honest with your patients, and then you'll get good results. And there is a learning curve both for the surgeon and for the technology, and I think you've got to embrace both those as well.
Any other questions? Thank you so much.
Okay, pleasure.
We have a little